In terms of definitive treatment options with good track record of close to 20 years, there are three modalities that have been shown to have an excellent outcome in terms of curing you of your disease should you fall into the early stage prostate cancer. One is the surgical modality. There are different ways of approaching it surgically. One is external beam radiation therapy. There are different ways of approaching that as well. Or placement of radioactive seeds inside the prostate to kill the prostate inside out. Surgical approaches, which has been used for many years, there used to be just radical approaches. You would get an open, what we would call an anterior approach or retroperitoneal approach. And what that would mean is the surgeon would open you up, go inside, dissecting the prostate out, cut above the prostate and below the prostate, and put your urethra back together. So basically, your plumbing is going to be rerouted. What that means is there may be about 10 to 15% risk of having urinary incontinence. Dr. Walsh came up with a nice approach, what's called a nerve-sparing prostatectomy. So if the nerves that run right along the prostate are spared, the chance of you preserving your sexual function after the procedure is high. It's never going to be as good as it is now, but you would have somewhere between 30 to 60% of chance of preserving your sexual function. What also goes into the equation is your other risks that go along because of your age, because of your comorbidities, because there's going to be risk of bleeding, infection, anesthesia, and just regular old surgical side effects that might be going on because of those comorbidities or medical problems you may have. There is a period of recovery. You will need to have a catheter in for a period of time. And over the years, the push has been really going towards minimally invasive procedure. So the laparoscopic procedures gain momentum, as well as robotic or robotic approaches. You might have heard there's a device named Da Vinci. And what they do is they minimize the trauma and invasiveness of the disease. It's still of the procedure. It is still a surgical approach. So same procedures need to be performed, except it is done through little ports that are made, and it gives a better visualization to the surgeon, and there are studies out there that show lesser hospitalization with lesser blood loss. However, you want to choose your surgeons wisely to make sure they have done many of these procedures, because it's still a surgical procedure, and that would be one question you should ask the surgeon. How many of these have you done, and how comfortable you are, and what are the possible side effects and comorbidities from this procedure I may experience? Surgical option was one of the options on the table. I'm going to put it aside. We talked about it in somewhat of a detailed format. Radiation options, radioactive seed implants is one of the modalities that can deliver very high dose of radiation on a selected group of patients. The patients that choose to go on this modality, they usually have to have a good urinary side effect portfolio to start off with. They have to be able not to get up at night so many times to go pee, and not so many frequent urination. There is the international score sheet that we usually have patients fill out before we recommend this procedure. Patient also should be able to tolerate a minimal surgery, because this is a mini surgical procedure that gets done. So it is not for everyone, but for the selected group, it usually offers a very good response. It is quick. It is an outpatient procedure. The first procedure that gets done is a volume study. So we visualize the prostate. We come up with a geographic map of the prostate. Then at a later procedure, they come in, we place seeds into the prostate under ultrasound guidance. So there is an ultrasound in the rectum that guides us where the prostate is, and we place the needles into the prostate and deposit radioactive seeds to sort of implant the prostate with radioactivity that gives off its radiation over the next 3 to 6 months to kill off the prostate from inside out. With external beam radiation therapy, it's more prolonged. It is not as convenient as a seed implant. It qualifies many more people for this procedure, and the terms you want to watch out for are image-guided radiotherapy, IGRT, or intensity-modulated radiotherapy that can administer radiation over several weeks. With this modality, radiation comes from outside in. With radiation, in any form you choose, the side effects are a little bit different than the surgical side effects. The side effects of radiation are more GI and GU toxicity, meaning because of the location where the prostate sits in the middle, you have the bladder on top and you have the rectum on the bottom. Because of the exposure of radiation to adjacent organs, the patient will experience some worsening of their urinary and bowel side effects. The urethra runs right in the middle. That's why it's very essential for the patient to start off with good urinary function to start off with. The bowel and bladder toxicities are usually limited. They subside down and go away. And it is rare for it to persist long-term wise. However, the risk of that is never zero. It's somewhere between 1 to 2% for it to persist and not go away with medical management. There are other modalities up in the horizon that are coming, and in the radiation world, for example, there is something called a robotic radiosurgery. It delivers radiation a little bit more accurately and precisely. It's still, the outcomes are premature as compared to the old radiation treatment modalities. It does have some benefits, but you need to talk to your physician to make sure you qualify for those procedures. There are some up-and-coming procedures, especially in Europe and Asian countries, called high-intensity frequency ultrasound. It hasn't reached FDA approval in the United States yet. And techniques as freezing the prostate or heating the prostate, and the track record is not as long as the previous modalities. So the ones to focus, the traditional ones with the 20-year track records, were the ones that I highlighted. Once you have had the prostate treated with any of these modalities, one of the best surrogate markers to see how effective we have been with the treatment is the PSA. For surgery, after treatment, we expect the PSA to fall down very close to zero and remain there. With any of the radiation treatments, we want to watch the PSA gradually over the next year or two to fall down and really reach low values before you can say patient is really cured of the disease. However, there are little graphs you follow and you say this really follows the norm. If, unfortunately, patients fail out of any of these procedures, always hormonal therapy can be added to suppress the male hormone that usually feeds these cells, cancer cells, to grow. And there is up-and-coming inventions, things like vaccination for prostate cancers that fail traditional therapies, and it is up for FDA approval pretty soon, and there is some promising hope in the horizon. To summarize, I want to let you know you are going to do just fine for years to come. And you should expect a very good, healthy life with the same life expectancy and the function that you have had. And depending on the side effect portfolio of these treatments, take that into account and see which ones are really high in your mind if you were to experience it and you could live with it for the rest of your life. And that should help you decide which way to go for you. Best of luck with your treatment.